minimally invasive. Oh, I'm just going to say it again because it looks like we just started live streaming. Okay. So welcome. Today we are here to talk about endometriosis and infertility with a very exciting panel. And I am Dr. Karli Provost Goldstein. I am a minimally invasive board certified endometriosis surgeon. And I do a lot of hormone work and complex pelvic cases. And I have the pleasure of being joined by some friends today. So we have Dr. Shiva Talebian from CCRM in Manhattan, a very renowned fertility clinic in New York. We have Dr. Mary Sabo, who is an acupuncturist and wellness provider and guru with fertility. And we have patient advocate Dana Davis is also on here. And so we are just going to introduce and say hi to everyone. And give me 1 second. Okay. And so what we are doing with these Indo Exchange series, we're excited to have lots of friends join every month and go through complex topics that relate to endometriosis so that patients and friends and family members and even clinicians can learn more about this disease and have a collaborative discussion with no gaslighting involved so that patients may learn more about the condition and different options they have. And so today, the focus is on endometriosis and infertility. And endometriosis, I want to say at the beginning that it doesn't always cause infertility. Some patients may be able to get pregnant easily, and they may go on to have full-term pregnancies without issue. And so we don't mean in this discussion to say that everyone that has endo may be doomed and have issues with their fertility. But it can be quite common with endo to have certainly a little bit more difficulty achieving pregnancy and sometimes maintaining it. And so today we're going to be discussing all of the ins and outs of that. In general, why does endometriosis impact infertility? There's multiple reasons for that, and we'll be going into that a little bit more with the lecture. But I first want to introduce our panelists. So Dr. Talebian, do you want to say hi?
Yes. Hi, everyone. I am Shiva Talebian. I am a board certified reproductive endocrinologist and fertility specialist here in New York at CCRM. And I have been practicing fertility medicine since I finished my fellowship in 2008. Um, and I am very excited to be here today to talk on this panel with this amazing team. And I will say that as I've gotten deeper into my career, I I see endometriosis every day. And I do think that we're learning much more about it. And I think it's really, really important that we start talking about it so that other practitioners can also understand some of the subtle symptoms and that patients also can kind of listen to their bodies and be cognizant of what might be endo so they can also advocate for themselves as well.
Awesome. Thank you. Dr. Mary, you want to take it away?
Thank you. I am Mary Sabo. I'm a doctor of acupuncture and Chinese medicine and founder of an integrative reproductive health clinic in New York City called Lily and Horn. I've been practicing since 2007, and I also provide on-site acupuncture at CCRM New York, where Dr. Talebian practices. And so I collaborate a lot with those physicians. We share a lot of patients, but my clinic sees patients from every IVF clinic in the city. We specialize in reproductive care, in particular fertility, but we also support pregnancy, postpartum, and perimenopause. I have, just like Dr. Talebian, in part because I've been sharing a lot of patients with her, increasingly been seeing and focusing on endometriosis as I go throughout my career, both with my tools of acupuncture, herbs, supplements, diet, lifestyle modifications for those patients. But also I have just in the past couple years been more and more likely to recommend or back up a physician's recommendation of surgical intervention for patients we suspect have endometriosis. I get questions all the time about this, and sometimes I'm the one that brings it up with the patient. And it can be a really difficult conversation. It can be very confusing. So I'm thrilled to be a part of this conversation, not only to contribute what I've learned and teach my patients, but also to learn from you guys, which I do all the time when we share patients. So thank you for having me.
Absolutely. So fun. And Dana, let's have you, if you don't mind, give a little bit of your story for the patients that are watching, and some things that you wish, were elucidated or things that you sort of wondered about when you were going on this
Yeah.
journey.
Yeah, absolutely. So I am a IVF and endometriosis patient of everyone on this call. So this is my care team. I'm very lucky to have all three of you. So I started my journey with infertility about a year ago. I was having some very minor symptoms that just seemed a little bit off, irregular periods, some pelvic pressure, nausea, that kind of thing. I went to my OBGYN, they did a workup, basically said nothing was wrong except I had slightly low AMH for my age. They recommended that I try and conceive for a year and just kind of see what happens. And if that didn't work, to come back to them. I'm a little bit more proactive than that. So I wanted a second opinion, which is how I ended up seeing Dr. Talebian for the first time. And through our kind of initial meetings, deduced that IVF was the right path for me and my husband. So we started our IVF journey in August. Initially, things were going really well with our first round, but pretty quickly into the process, we saw declining results. Again, I didn't know I had endometriosis, but after the second round, we only got mosaic embryos, and that was the first time that Dr. Talebian brought up, the potential that I might have endometriosis, and kind of explained that typically when you see a patient going through the process and seeing kind of declining results with each round, that can often be a reason why. I also started at that time, Mary, I think that's when I started to see you as a patient. And I actually think you were one of the first people to say, maybe I had kind of silent endo or some very minimal symptoms of endo. Again, like irregular periods, GI issues, that kind of stuff that no one had ever really flagged before as potentially endometriosis. And so we kind of continue through the process with this, in the back of my mind of like, I might have endometriosis, we might need to do more intervention. And after my third round, I think it was very clear to all of us that I did have endometriosis, which is the point at which I went to go and see Dr. Goldstein. And that's when we really started to talk about excision surgery and what kind of more intervention would look like. I think, immediately it was a question for me of when and not if. I was very, comfortable with the idea of surgery. I kind of felt like I didn't want to, have something that was getting in the way of my fertility, if there was something I could do about it. And so we kind of started to work on a plan with the three of us on timing, how to think about, doing further rounds of IVF relative to surgery and timelines and all of that. And so ultimately I decided to do my fourth round and then did an excision surgery with Dr. Goldstein, which went super well. The recovery was not terrible. And it really allowed me to move forward in the next steps of IVF, knowing that the endo was, as well handled as possible. So I can pause there. I don't know if there's more that would be helpful for me to share about kind of the journey and some of the decisions made along the way.
Yeah, I think that's great. And I know that, when we talk in our office that we always go through a lot of symptoms that patients may be having, right? And when we go through these questions, we kind of go through it by system. And so, we start with the bladder, we go through things that may be common in endo patients, maybe frequent urination, frequent kind of UTI-like symptoms, but the UTI test comes back negative. What else do we see? We see uterine cramping, irregular pain, very heavy pain before the period sometimes, and then the period itself, the pain gets better. But it's important to know with all these endo symptoms that not every patient follows the book exactly and has exactly those symptoms. And not everyone with endo has very heavy periods or very painful periods, right? Sometimes they may have more bowel symptoms or other things happening. They may just have a few bowel symptoms, nausea, bloating, some constipation, and especially around ovulation. And then they may feel some sharp pain with ovulation, or they may just have painful intercourse and infertility. And so the range can be really wide with all of that, right? And going through all those questions, I think you said it earlier that things were sort of passed over often, or your bowel symptoms, no one really attributed it to your period or your cycles, right? And if you kind of look back on many years, you may start to see that those things followed a pattern and followed a timeline, right? And if you kind of think about it in the hormone stimulation, right?
Yeah. Yeah, absolutely. I mean, I think it was one of those things that like once I had a diagnosis, a lot of things made more sense
Mhm.
that I had experienced probably throughout my 20s that I had kind of always written off as like being a woman, like, oh, that's just like, you know, something that happens. And some pieces definitely started to come together for me.
Sure. And after your recovery, did you notice things changing with those systems in your body, that things changed a little bit with the bowel movements, or changed a little bit in your, feeling of your pelvis, or how you accomplish things?
Yeah. Yeah, I definitely think I noticed some slight changes. And, you know, I also think a huge piece that comes with doing the surgery is just peace of mind. Like, I think prior to doing the surgery, whenever I would have, you know, like a weird symptom or something, it would just cause a lot of anxiety and nervousness of, you know, is something really wrong? And, you know, as I was going through the IVF process, like knowing once I kind of knew I had endo, it definitely was something in the back of my mind that I knew could be negatively impacting the process. And so I think, you know, in addition to the physical piece of it, like there's just a huge peace of mind that comes once you do the surgery and, you know, like knowing that you had gone through and literally taken everything out that could be negatively impacting fertility and kind of given me, you know, effectively like a clean slate to move forward with was really like just again, like gave me a lot of peace of mind moving through the next steps in this process.
Absolutely. That you put your best foot forward, right?
Yeah.
Yeah, I like to say, a lot of times with patients, it's like no amount of, we can drink all the green juice, stand on our head, do all this yoga, do all these things. But when the actual systems, all where the eggs are developing and the ovaries are pushing out eggs, and the fallopian tubes are picking up the eggs, and they're transferring from the fallopian tube into the uterus, and they're doing all these very important jobs. Any one of those little steps can go wrong. And when you actually really look at it every day, Shiva, I'm sure you probably feel the same way, but it's a miracle all the time to me that people get pregnant all the time on their own.
Right.
Like, to me, I'm just like, I'm always just still
Right.
dumbfounded by it. And I've been doing this for so many years. It's so many little intricate steps that need to work, right? And so I think that's the important thing, is that one, it's never the patient's fault. And you do so much. I know all of my fertility patients that I see, like the binders of information, all of the supplements, the granny pill containers with your millions of supplements. It's a full-time job and everyone's working so hard at it. And it's important to, I think, take the pressure off of that and elucidate what's going on, and then really clean and restore things and flush it all out. And I think that's one of the most exciting parts of what I do, is that is we get to sort of get to the bottom of things, and that's very, it's a lot of pressure built up to before the surgery. And then after the surgery, it's sort of a big emotional relief of really finding some answers. So let's see. Okay. So, Dr. Talebian, can you give us some more secrets or tidbits of how endo, I talked a little bit about it, but how endo affects different aspects on the fertility train?
Right. Well, I think kind of it's a nice segue after what you just explained about how does pregnancy even happen naturally, right? We're born with our eggs, they're developing in our pelvis, they're exposed to the various proteins and cytokines that surround our ovaries. Our fallopian tubes have to be pristine to allow this microscopic egg to be picked up, and the sperm has to swim and they meet in that fallopian tube, and that environment has to be perfect, right? So it really, even for me, is a miracle that this ever happens naturally, right? So with that said,
Correct
I
one of
think,
those misconceptions from the cartoons.
yeah,
The tube is not holding the ovary like an ice cream cone, like we
no,
always see it in the cartoons and pictures, right? And
right, no,
people are always so confused when I actually draw real pictures or show them the
yeah,
pictures, that Oh, it's not like that perfect ice cream cone. So even though the
Yeah.
anatomy, like cartoons and pelvic figures always draw it like that, like the ovary is sitting here and it's sitting perfectly on top of the ice cream cone and the egg will just fall into the tube. That's
Right.
actually not how it works, right?
Right. And it's only when we do surgery, I don't do surgery anymore, let you do that. But when we did do surgery that you actually had a visual of it, you're like, wait a second, that's not what the textbook shows, even with pristine anatomy. Um, the question as to how endometriosis can negatively impact fertility is still there. It's all theories. We don't know exactly why or how. And like you said at the start of this, of our talk, that there are some women who have severe endometriosis and get pregnant, right? And don't necessarily struggle to have a pregnancy, right? It's an extremely mysterious, enigmatic disease, and it doesn't behave the same in every woman. The symptoms are very varied and subtle. But I guess what I try to envision is that it's an inflammatory pelvic condition. And not just pelvic, right? It could travel up into our abdominal cavity, into our chest and lungs, right? But it's an inflammatory condition. And what I sort of think of is like this like soup of just proteins, enzymes, cytokines that are negative, that are and just making it difficult for egg and sperm to come together, or maybe when that egg's released, that those various negative factors floating around are affecting the quality of the egg, so it just doesn't fertilize, right? Or maybe embryos can't implant, right? Or we do know that in some cases of endometriosis, it results in actual scar tissue and it distorts the anatomy, right? So it can cause dilated fallopian tubes or blocked fallopian tubes, right? And we know that the fallopian tubes are this tunnel that has to be pristine for everything to meet. So, there are just true anatomic ways that the scar tissue is there and that could prevent pregnancy. But as we know, we can do surgery in some of these women, and anatomically, things are still looking visually good, yet there's still all this negative environment that is preventing the pregnancy. And we know that it is because we can clean that all up. And again, it has to be a surgeon who really knows what they're looking for, who cleans it up adequately. And then we do see improved pregnancy rates after, whether it's natural or through, assisted reproductive technology treatment, right? And I guess you and I can touch a little bit upon the medical literature that's out there regarding endometriosis and fertility. And I was taught the literature that existed when I was in my fellowship back in 2005. I was taught that in women under the age of 35, there was potentially a role or benefit for cleaning up the endo to improve their outcomes. But in women over 35, the literature said just nope, just go straight to IVF. And I don't, we're working on updating our literature, but I think I look back and I discount a lot of those studies because I don't actually think the surgeons that they were looking at and the population they were looking at were actually getting good surgery to treat the endo. So I think there's a shift, and things are changing, and we see this as IVF is becoming so much better. We're improving our IVF. We chromosomally screen our embryos, and yet we still have unexplained implantation failures. And, a lot of those cases, I think, is silent endo. I mean, it can, there's so many tip-offs to me, where I think endo. When I have women under the age of 37 who've had unprotected intercourse with partners who have sperm and their tubes look open, and they've not had a single pregnancy test for a year plus, to me that's a big tip off of endo. Right, like that, it just doesn't fit the box. That doesn't make sense. Or I get tons of patients who see me for second opinions where they've failed multiple embryo transfers of chromosomally correct embryos, and that's another big tip off to me. So, yeah, I can sort of stop now and people can chime in and ask questions, but it's definitely very prevalent and it's out there.
Absolutely. And I think, there's a lot of confusion with the studies, right? ASRM publishes in its guidelines for endometriosis and endometriomas, and we go over this a lot with my patients too. With endometriomas, they say, okay, don't remove them unless they're 3 centimeters or above. But, it's always funny to me. It's like, what magic bullet is a 3 centimeter endometrioma that's not in a 2 centimeter endometrioma? And what I see in surgery and in practice is that it doesn't really matter the size of the endometrioma. The destruction around the pelvis can happen no matter what size endometrioma there is. And I've seen, often that endometriomas that were larger, and then they rupture, and, then they're suddenly become smaller. I always tell a patient that's not necessarily a good thing, in my opinion. It usually means that the endometrium has leaked, and then it's caused a glue and a inflammatory fibrotic state around it. And so I see that all the time where people are like, oh, well, I've been followed for this endometrioma for 4 years now, and it was 4 centimeters, then it was 5 centimeters, then it was 6 centimeters, and now it's 2, so that's great. And I'm like, and how are you feeling? And and there's a cost to leaving that in and letting it sort of attach to everything and fester. And so, that those studies say 3 centimeters or above, endometriomas should be removed. There's newer studies that state in stage 3 and 4 endo, there's a clear benefit for fertility afterwards when you do surgery. But the stage 1 and 2 endo, there's not as much studies on that. And I think that's reflective of the fact that a lot of stage 1 and 2 endo patients are not always diagnosed. And so they're not offered a laparoscopy, and it's not picked up on imaging. So there's a huge pool of patients walking around that actually just don't ever get a diagnosis. And so we can't really say, okay, does surgery help it or not help it? And we see in our own data that it doesn't matter if it's stage 1 or 2 or 3 or 4. It's irrelevant. When we do this cleanup surgery and then I send them back to you, they do fantastic. They get blastocyst embryos that are normal when they weren't before. And we change the quality on things. And I've seen patients, even to that study of the ones over 35. I have patients sometimes that come to me at 40, 41, and they're refused IVF based on their AMH being too low now, or their FSH being too high. And so the endo surgery at that point is like a Hail Mary pass. And we've still seen great results in blastocysts or pregnancies after surgery at 41 spontaneous, even without IVF. So that cleaning that endo, it's not like there's a finite time of where we have to do this, or we have to, there's always a time, right? And there's always still, I mean, yes, if we're doing endo surgery on a 50-year-old who's still trying and has bad endo, yeah, there's some time limits, right? But I didn't mean to say it like that, but I do think that the data is evolving and we need better studies. And there is a clear benefit no matter what stage of endo it is, and in flushing the system and sort of restoring the anatomy and repairing it, So
Yeah, I was definitely going to say that. I'm the IVF doctor, right? And I am really blessed to work with an amazing lab that makes phenomenal embryos, right? Like CCRM was instrumental in developing blastocyst culture, testing chromosomes, freezing, right? 2025 technology is excellent, yet it still falls short for many women. It doesn't, like, we still put in embryos and they don't get pregnant, or they're not making good embryos. They don't make blasts in the lab. And the one thing I say is endometriosis, if it's there and you go to the right person, can actually be treated for that period of time. And it's something like it that we could do, right? Because again, sometimes I feel like helpless. Like if IVF can only do so much, it's never 100%. And at least with that endo, sometimes it's just patients like, but I don't understand, but I don't have pain. And I'm like, maybe just go do surgery, at least just give us some answers as to what's going on here. So I do, because again, there's some screening tools for endometriosis, right? It's really hard to diagnose. There's no good blood test. Yes, sometimes if you see an endometrioma on the ovary, which is an endometriosis cyst on the ovary, that suggests that that is there. But even MRIs oftentimes cannot detect it, right? There is a biopsy that was developed maybe 8, 9 years ago by a company. It's called the Receptiva uterine biopsy. It's a uterine biopsy that's done 7 to 10 days after ovulation, and it looks at a biomarker called BCL6. And for patients that don't have classic symptoms or or like I offer this test. And a lot of times patients, when I call them and I say your BCL6 is elevated, it's like really crushing news. And sometimes, and I'm like, yes, we don't want you to have endo, but I'm like, the silver lining is if it's there, it's one thing we can actually pinpoint and potentially treat that might improve your outcome, right? So that's the good news with it, is that there are treatment modalities for it. There's medical management, surgical. A lot of times when it's this long history of unexplained infertility or failures, I like the surgery option because it gives us that answer, right? And I think for like Dana was saying, it's that sort of peace of mind also, like, okay, so I'm not, making these symptoms up. There is something going on. My AMH, again, AMH is a marker of your egg reserve. And endo may accelerate the rate of loss of our eggs at an earlier age. So it is something also I think of in my kind of patients under 35 with a lower or lower-ish AMH, that maybe there is endo in the background as well.
Yeah, I think doing the Receptiva is definitely something, like if you're going through this process and you're starting to wonder, if your doctor hasn't brought it up, I think it's worth asking about, because exactly as you're saying, Dr. Talebian, like as strange as it sounds, I feel like there was a part of my journey at which I was almost like, I was almost welcoming that diagnosis, because it finally was like the missing piece for me. And it was an explanation for these things that before that, like we didn't really understand why certain things were happening. And obviously, like it was not ideal to get the diagnosis, but it did also give me this sense of control of like, okay, now we know what we're dealing with. And like there are specific tools like surgery and other things that, Mary and I worked on that we can do to combat this. And we're not just kind of like guessing at what's going on. It definitely, I think the certainty in some ways almost made the rest of my journey much easier once I had that.
And Dana, I'm sure you probably heard this, like, oh, from a primary care doctor, but oh, you look young and healthy and you're fine. And, you eat well and you exercise and you're doing all these things. And so I see a lot of patients that feel like their body is failing them on some accord by having this or by having infertility. And it's important to discount that as it's nothing you did, right? It's something that's happening, that internal, that we think maybe developed even when you were in utero in mom's belly. And it's been growing over the years, and being healthy and doing all of these things with lifestyle will only help you for the rest of your life. And even when you have endo, those strategies that Mary's going to talk to us about, things can help you on your journey, even with fertility, but also in life. And so I always think that no, it's not a downfall that you're super healthy and you still got this. It's okay. It happens no matter how hard we try and how healthy we are, right? And so those strategies in life can always help you down the road and help in the fertility journey. So I think that and finding the answers and then knowing how to help your body come to the right place to heal and to be fertile and to do all these things is really important. It's fascinating, right? So
Yeah. I'm going to jump in. I always say that both IVF and endometriosis surgery, both tools are both diagnostic and therapeutic. So for a lot of cases where people trying to get pregnant, it's like, they run out of, they're trying everything and it's not happening, and maybe they don't want to do IVF, but it can be super helpful in understanding, where is it breaking down. And endometriosis too, like if you get to the IVF phase and that's not working, I feel like the surgery is both diagnostic and therapeutic, and that you really can't diagnose endometriosis without it, right? Like, I wanted to ask about the staging, like how do you get the staging in your diagnosis if you haven't done surgery?
so it's only an estimate at best. If you haven't had
Okay.
surgery, then staging is really an estimate. So when we see an endometrioma chocolate cyst on the imaging, First of all, we can say, okay, with high likelihood on ultrasound and MRI that that's an endometrioma. But there are always cases too, not always, but there are some cases where you go in and actually it's not an endometrioma. It's another type of mucinous cyst that looks the same kind of echogenicity or speckled like pattern on ultrasound or MRI. So imaging ahead of time is not a biopsy. Imaging ahead of time is a tool and it's something that we can look at, but it's not the same as having a fine needle biopsy of your thyroid or your breast where you're actually removing a little bit of tissue and finding out what it is. And that's not practical to do on the ovary. You could do it in an IVF setting. Like if Dr. Talebian did a retrieval on someone and got back endo fluid, then we would know it's endo, right? But that's not very practical to go sort of rupturing an endometrium on purpose to get that diagnosis.
Right.
And so yeah, we don't know staging until we actually go in for surgery and we see what the organs are that it's involved on. So stage 1 is peritoneal, which the peritoneum in the abdomen is sort of like this saran wrap skin layer all over all of the organs coating it. And endo first sits on these layers. And stage 2 is more involvement throughout the pelvis, and a spread throughout, but not with ovarian involvement. Stage 3 is when you have ovarian cyst of endometriomas. And stage 4 is when plus or minus endometriomas, but there is distant organ involvement. And that can be the bladder, the bowels, the diaphragm, all different places around the abdomen, and that it actually goes to those areas and infiltrates them. And so in order to get that diagnosis, we can have a strong suspicion on MRI and ultrasound and even physical exam based on how the pelvis feels. But when we actually biopsy and remove those lesions and send them to a pathologist who looks under the microscope, then they say, yep, it invaded the rectal wall. That was endo stage 4 of the rectum, deeply infiltrating on the rectum. And so they actually measure it. They measure how deep it was. And they say, yes, it was endo. Yes, it was this. And so that's how the final staging is done, similar to having a strong suspicion of a certain type of cancer and going in and not really knowing until you go through all of the biopsies and analysis. And so endometriosis is much the same way in that respect.
Yeah, I hear a lot my patients who have discussed with some provider, about the possibility of endo, and I hear countless times like, oh, you don't have endometriosis, just based on like, oh, you don't have painful periods, right? But I think in the fertility world, there's so much more awareness, in part because we can biopsy embryos now, and we know it's not because of the embryo, right? Like that was always, I think, before when we were only doing fresh transfers, I didn't hear as much about endometriosis the first 10 years of my career because we were just doing like fresh transfers. But with biopsying blastocysts, I think it's now a lot more on the radar, and the invention of the Receptiva test, which maybe Dr. Talebian, you could talk a little bit more about that. There's like 2 things you measure, right? And it's not a diagnostic tool either, but it indicates a high likelihood, right?
Right. So yeah, so the Receptiva biopsy, it's just a screening tool, right? It is not definitive. Unfortunately, again, the only way to truly know if we have endometriosis is to go in and do surgery. Or like Dr. Goldstein said, if there's an endometriosis like cyst on the ovary and that gets aspirated, yes. But the Receptiva is ideally, I recommend doing it 7 to 10 days after ovulation in a natural cycle. So early in my career, I used to do it like a week after the egg retrieval, just for timing purposes. And I have to say, every single patient was positive for the BCL6 marker. And then when I started to do it more in natural cycles, I found that actually not every single patient is elevated for it. So it looks at this biomarker called BCL6 that if it's over a certain threshold, suggests endometriosis. Again, and the degree of that number is not really thought to be indicative of the stage or the severity. It's really just supposed to be like a marker of inflammation. Again, it's hard to kind of look at that because a lot of times we do that Receptiva biopsy in the setting of somebody that has symptoms or unexplained failures, right? So it's not something that every person who comes through the doors with infertility that it's offered to them. You know, and why not? Because you may have false positives in that scenario, right? So I tend to do it in patients who have unexplained infertility, some subtle symptoms of endo. There's other patients who just they come in with unexplained infertility as we're doing treatment and going through the process. I'm like, I highly suspect you have endo. We start talking. Yes, they have GI symptoms, they have all these other symptoms. A lot of times I'm like, listen, I really think you have it. I don't, we could do the receptiva biopsy if you want, or you may just want to go speak to a surgeon and just talk about that. Because if you're already symptomatic for it, then if you're already symptomatic, I'm probably going to recommend that you address it before we go ahead and do an embryo transfer, which, you know, again, we can segue a little bit to the timing of surgery. Obviously, when I see
And why
patients,
don't we tell them too, sorry, how
yeah, go
painful
ahead.
is the receptiva? So the receptiva is an endometrial biopsy. So you have a biopsy inside the uterine cavity, not the pap smear where it's the outside of the cervix, but you actually have a little straw put inside the endometrial cavity. It can cause a lot of
Oh,
cramping,
yeah.
to like inserting an IUD. But it can cause a strong cramping when you have it. Sometimes patients may need something like a Valium beforehand, some strong ibuprofen, and a day of rest after that happens. But Dana,
Right.
do you want to tell us how bad that experience was for the patients watching?
I mean, it's definitely not fun, but it's very short. I mean, I don't know, Dr. Talebian, how long did that take? Like 5 minutes?
Yeah. Yeah.
And it only hurts for me, it only hurt while we were doing it. Like it didn't, I got up and walked out of there and like didn't really feel anything. So I would recommend like a Valium or something just so you're a little bit more comfortable and a little ibuprofen, but it's not so bad that like you shouldn't do it. You know, I'd say it's worth it to have the information and it's pretty short in terms of the experience.
Good. Thanks.
I see a
Yeah.
lot of, I feel like Dr. Talebian is doing this test a little more frequently and is comfortable with understanding the results and knowing what to do with it. But, you know, there are a lot of doctors out there who are kind of skeptical of it. It's a newer test. And so, you know, if you're watching and you don't have Dr. Talebian as your doctor, like it may be a conversation that, you know, you have to push forward to ask about having the biopsy. And then what do you do with it? My understanding, like the literature kind of indicates that if you get a positive, it's kind of it helps to prepare for an embryo transfer. And usually the treatment is 2 months of Lupron to kind of shut the ovaries down, which helps suppress the endometrial tissue. And then your body can clean up inflammation. And then you do a transfer without having a bleed before the embryo goes in, like a period, which would inflame that tissue. Um, I'm talking a little bit about the indications for receptiva. Like usually when you get a positive, most clinics would say the course of action is to do 2 months of Lupron, right? That's what the test says.
Sorry, guys, I got disconnected for a
It's
second.
okay.
So again, so the receptiva, once we get those results back, it depends, right? If this is somebody who has done IVF, has some embryos banked, frozen, but we suspect maybe that they have endometriosis, then, you know, we would do the receptiva, and pending the results, if that BCL6 is elevated, there's, you know, we want to address it. So there's the, you know, surgical route or there's medical route. And the medical route is, there's a few different protocols out there. I think the original route that the kind of some of the literature looked at was 2 months of Depa-Lupron, which is long-acting Lupron, prior to the embryo transfer. So, right, Lupron basically tells your brain, don't ovulate. So it kind of puts you into a temporary medical menopause. And the thinking is that when you ovulate, estrogen kind of feeds the endometriosis, which like might flare it. So there's some thinking that if you do this long-acting Lupron and you're in a menopausal state right before the transfer, maybe you quiet down all that inflammation and maybe there's a better chance of that embryo working. I'll be very frank. Initially, when the receptiva came out, kind of most patients I routed that way. It ends up being a 3-month process, 2 months of the Depa-Lupron, and then the third month is when you can implant. Patients that second month many of the patients have terrible side effects. Not everybody, but I would say like 50% had some pretty severe side effects, night sweats, flushing, but the depression was like a bad one for some patients. And just over time, I said, well, there's a couple endosurgeons I know that are out there that are really good. Maybe I should send patients that route. And it was faster. Patients actually had an answer. They were treated, and patients were telling me, I realize now I realize how better I feel now after this surgery and after this cleanup than before. And I'm realizing now that I actually suffered from endo for quite a long time. So I really have not used the Depo-Lupron in quite some time. Sometimes we may use it if there's just been a long gap, like if it's maybe been over a year from their surgery and now they want to implant, so maybe we'll do it then.
Or
Or sometimes I
adenomyosis.
was just
Yeah.
going to say adenomyosis. That's the other scenario. Maybe they do surgery,
Mhm.
but they also have a condition called adenomyosis, which Dr. Goldstein can speak upon. But that might be the other scenario that we may use it.
Yeah.
Yeah,
And
but yeah, go ahead. Sorry.
oh, no, it's fine. Adenomyosis is a sister disease of endo. It's where there are glands and stroma similar to those in the endometrial cavity, but they're growing inside the walls of the uterus and the muscle of the uterus. And it creates very, very painful periods because you're having mini periods all inside the muscle wall where it's supposed to be contracting at a certain rate. And instead, when these cysts and glands are there, it's very asynchronous and very painful. And so it can be sort of like a sister disease, a similar disease of endo, and it can create a lot of trouble with implantation and with pregnancy. Sometimes there is a single focus of adenomyosis that's amenable to removal if it's like a fibroid. Often, though, adenomyosis is diffuse and kind of peppered all throughout the walls of the uterus. And in those cases, I really don't recommend removing it. I recommend maybe that suppression protocol if a normal transfer protocol doesn't work. And that's where, cases like that, Dr. Talebian and I work really closely together about, okay, what are the best options and what have they tried and what can we do next? And how do we downregulate the estrogen or not give any estrogen and just give some progesterone and have them send them for some acupuncture and modify the whole environment to help that work. But the data for Lupron is good for adenomyosis and improving success of a successful transfer. It's not as great, statistically significant as it is for endo. Endo is not as significant. It's better to excise endo than it is to suppress with Lupron. So, Mary, sorry.
Yeah, that makes so much sense. Um, when we were talking earlier about the endometrioma and like the 3 centimeter versus like the bigger ones, whether or not to excise, and I feel like Western medicine really is so, so good and precise, and science is amazing at like creating protocols and ways to advise how to treat a patient. But endometriosis is so unique for each individual. And I feel like that's where Chinese medicine really comes in to excel, where we never kind of one size fits all with patients in Chinese medicine. Everyone always gets a very unique treatment, both with like which acupuncture points we're using, dietary advice, custom herbal medicine. I have a pharmacy in my practice where we customize herbal blends for everybody. And we're looking systemically at everything too. So we're never, even when I'm working on fertility, we're never just looking at the uterus and ovaries. We're also looking at digestion. We're looking at sleep hygiene and health. We're looking at energy levels, moods, immune system, everything. We never separate the body from the organs from the rest. And so I think endometriosis is so prevalent and is often systemic, and we catch it. I tune into it rather quickly, especially when there's digestive problems or urinary problems, um, because we're asking those questions. And I know Dr. Goldstein, you ask those questions too, because you're tuned in. But on average, it takes a patient, 10 years to get an endometriosis diagnosis. And really the only way to get a diagnosis is through surgery. And so by the time you're at that point, you're kind of at your wit's end, and it can be a really big struggle. Someone has a question, why people are constipated with endo. And it's not just constipation. Sometimes people can also have like severe diarrhea. And my understanding from a Western medical point of view is that it's inflammation. If you have endometrial lesions in your in your abdominal cavity or on your gut, on your large intestine, on your small intestine, it's going to irritate that organ. Sometimes I think like IBS is misdiagnosed and is really endo. I don't know if you see that too, Dr. Goldstein, but anything that can irritate your intestines, they'll either speed up or slow down, including food sensitivities. And people with endometriosis tend to have more food sensitivities. So gluten and dairy are the number one, number two food sensitivities. It would be helpful for women with endometriosis to avoid those foods or at least test them out. I recommend like 2 weeks of avoiding both of those things and then reintroducing one by one to see if you have a reaction. A reaction could be constipation or loose stool. It could be nausea, bloating, intestinal cramping, even things like foggy thinking, moodiness. It can, water retention. It can worsen allergies if there's like a histamine response. But if you identify your food allergen, then avoiding it can help calm inflammation in the body. So when I'm working with a patient that I suspect has endometriosis, or Dr. Talebian sent me this patient, and we're working on improving ovarian function and egg quality in preparation for a retrieval, I'm focused on body chemistry. So the way I see it is, especially in younger women, if I can help calm the inflammation with my tools and change the body chemistry, then the eggs coming down the pipeline can be their best selves. So I don't think of changing egg quality and that my magical tools are like somehow going to bring, an older egg back to a younger egg. What I think is if I can improve this body chemistry and the soup that is kind of marinating that egg, then it can be its best self without any damage as it's being matured. It takes about 3 months for an egg to wake up from its little storage follicle in the ovary to be either retrieved or ovulated. I think of it like a stage. Like there's always a set on stage performing. In a natural cycle, one becomes the soloist and gets to perform and ovulate that month, and the rest dissolve away, never to be seen again. And there's always a group in the wings and a group in the dressing room getting ready, and then the rest are asleep in like these little storage follicles. And this is why IVF ends up being helpful, because in an IVF, instead of having just the one soloist, all the follicles in that group get to perform on stage at once, and we get to retrieve all of those and try to find the good eggs in that batch. And so as they're preparing to get ready to perform and either be retrieved or ovulated, they're being exposed to your body chemistry. And so where things come into play with your diet and lifestyle, there are foods that make inflammation worse, and there are foods that can help mitigate inflammation in the body. And so obviously the things that make inflammation worse are all the fun things like sugar, alcohol, lots of caffeine, lots of processed food,
yeah,
Cheetos, but like you can have a little bit of those things. I try to think of it as a spectrum instead of a this or that. Where it's like, if you're on the spectrum of inflammation, these are the worst, these are the best. Try and stay over here, and you can have little treats over here every once in a while. So the Mediterranean style diet is one of the best for being an anti-inflammatory diet, and that is lots of organic fruits and vegetables. We prefer cooked vegetables over tons of raw vegetables. Those can be hard on the gut, especially if you have endometriosis. You probably have a little digestive weakness in there. And so having cooked vegetables is preferable. Organic is preferable. But also having lots of fiber, high fiber foods, nuts and seeds, plant fats, some animal protein, but look for grass-fed, free range, wild caught fish, things like that. And then whole grains. So when you make your plate, try and have as much as possible be recognizably from the ground or directly from an animal to lower the amount of processed foods you're having. And so if you can kind of build your diet in that way and also look for potential food sensitivities, you will give your body the best chance to decrease inflammation naturally, which can improve fertility outcomes and health outcomes overall. I mean, there's plenty of studies on that, right?
absolutely.
I think there's a few questions.
Yeah, there's
Okay.
a few questions. So, so Dr. Talebian, is frozen rather than fresh embryo transfer preferred even after you've had surgery to remove endo?
So it's a sort of, I think the answer to that question is it depends. So I, at CCRM New York, I pretty much only do frozen embryo transfers because I want to chromosomally screen my embryo first. So even in under 35-year-olds, even if it's a 26-year-old anonymous egg donor, our goal is to transfer a single embryo with the best chances of resulting in a live birth, and that means it has an intact chromosomal backbone. So that always entails freezing the embryo first, okay? So but also, again, especially if this is unexplained infertility, or maybe we do know there's endo, I do want to make sure, regardless, that that embryo is chromosomally correct, and then do the implant. And in theory, if you're doing a fresh transfer, that means your ovaries are stimulated. That means your estrogen's kind of sky high. It's a supra physiologic. It's not a natural environment. So I would imagine, kind of putting aside the question of chromosomally screening your embryos, right? Because there are some centers, depending on where you live, depending what your options are for IVF, like there's some centers that just maybe don't have that technology. Their lab is not equipped to offer that. And, so fresh transfer may be the only option there. If that is the case, you might want to look for other places. But my concern with a fresh embryo transfer, even knowing that you have endo and the endo was treated, was that you might be slightly inflamed right after the IVF treatment, and that may not be the best environment to put that embryo in. So it's not my preference. I mean, I really, I love the combination of get the embryo chromosomally correct, it's frozen, treat the endo, clean it up, then do your transfer, right? I think that I have seen, we're starting to look at the data, but I've seen about 80% success rates with that route, meaning 80% of my patients are pregnant with the first transfer after an endo cleanup.
And I think it's also an opportunity, and I agree with you. I think the frozen embryo transfer, I've often seen it work in patients when fresh hasn't worked with endo. Anecdotally, I had endo for years and tons of embryo transfers, and the fresh never worked, and IUIs never worked, and the frozens did work when I had a programmed, modified natural progesterone only protocol, acupuncture, Chinese herbs. I did all of the things, and I think that gives the opportunity for practitioners like Dr. Sabo to help you clean the environment and then put the embryo back in after we've downregulated all these hormones and help your system sort of recover, relax, get ready. And I think it's a break, right? But it's important that if patients can't get to the day 5 blastocyst stage, I have seen a few patients with endo that have had success with a fresh transfer. I even heard one the other day. It was so curious. Literally day 1 or 2, it was wild, or in Boston, that couldn't get to day 3 or day 5 even, and had a pregnancy success from that. So it's not to say that that's common, or but I would say that if you can't ever get to a day 5 blastocyst, then that may be a role where sometimes they are just going to do a fresh transfer on some day 3s or
Right.
something. The preference would really be to see if they could get to day 5 and to let your body really recover and feel good. And I would say for endo patients, like, oh, well, why don't you check back in with acupuncture and see how you're doing, and how are your pulses, and how's your system, and see if we're ready this month. If you're really relaxed enough and you feel good, if you're still having some recovery issues after surgery, you're still tired, you're still fatigued, then maybe your body's not ready that month. Maybe we should wait till the next month. And it's okay to push it one more month. We think the benefit for endo surgery is like that first 6 months to a year. It's okay to say, okay, let's take one more little break. Let's do some more acupuncture. Let's come back next month. Let's wait for the cycle,
But I also think if you are a patient who is doing IVF at a center with a very good lab that has, good high blastocyst rates, and you're not making blasts, and you've never had endo addressed, that's another tip off to address the endo, right? If you're seeing just sort of unexplained, very suboptimal embryo quality in a lab that has a very strong lab, that would be a reason, a tip off. Should we do a receptiva? Is there endo here? Let's dig a little deeper. And in that scenario, I have seen sometimes big cleanup of surgery and then better embryo quality after the surgery. So, there's a kind of a role for the surgery in both scenarios, right?
Absolutely. And I will very quickly, we have to wrap up really soon, but I will quickly share. So if anyone doesn't want to see pictures, please avert your gaze right now. But I just want to very quickly, I think pictures often speak 1,000 words, and you guys don't get to see this all the time. So in surgery, quickly, this is inside the uterus. We always look inside the uterus of the camera. I provide patients with pictures and videos of their surgery and a highlights reel to their fertility doctor of what happened. And in the surgery, we look inside the pelvis. This is the ovaries, the tubes. This is the uterus. This is the uterosacral ligaments. And there is endo all on this pelvic sidewall that may not be visible to the naked eye or to even a lot of doctors, but these are all tiny endo lesions that when the ovary is resting here, it's going to hit these spots. And this is a patient with totally normal labs, IVF for 2 years, and great hormone levels, but a lot of subtle endo symptoms. And she had a lot of endo there underneath the ovaries, and then went on to produce blastocysts for the first time post-op. So this is very exciting. And look at this. This is stage 1 endo creating an issue with infertility for 2 years without getting blasts, right? This is a patient with big endometrioma, big chocolate cysts in the ovary, and we see that there's already some cyst leakage in the posterior pelvis here, and we think that this could implant and become deeper disease later. I flush the fallopian tubes with dye, make sure they're open, clean out inside the cavity, test it for plasma cells, look at all these endo lesions, and then remove them all one by one. So we see here that this is a small endometrioma, 1 to 2 centimeters, which many doctors would say, don't remove it. What did this endometrioma do? It already leaked. It went up to the bladder here. It's all over here. It's blocking the tube here at the beginning of the tube. And this is a small 1 to 3 centimeter endometrioma. So what I just want to not be gory about the pictures, but I want to show that what I see when I look visually at these cases is, oh, it's no wonder this patient couldn't get pregnant. When we see all of this and we see the inflammation and we see the changes in the peritoneum and these cell layers, this is an endometrioma cyst wall that's very thick. We literally can see, and this looks terrible and it's a mess, and I'm sorry to show it, but this is supposed to be paper thin, and it is about 1 centimeter thick with fibrosis and scar tissue under the ovary. And under here is nerves and blood supply and the ureter. And so these patients have incredible pain and destruction in the pelvis caused by endo. And this one is a picture of the sigmoid colon tacked up with lots of adhesions, probably causing constipation and the stool to get stuck here before it passes. And the patient may do position changes if they have rectal adhesions, or feel like they have to massage the side of their abdomen to get the poop to come down if it's here and frozen. And so there are all different things that we can see visually that really help to see what's happening in the pelvis. So I just wanted to show some anatomy pictures real quick for you guys, so that we could see how this can be elucidating. So we may have time for one last question. Let me see. We did the frozen embryo transfer. We did the constipation, pain near the ileocecal valve. You know, we can talk about that more. Endometriosis can affect the appendix. It can affect, I'm happy to, go through cases and things like that for specific surgical or pain questions. But I want to really thank everyone today. We can, it's lovely to have you all here. And can you just say where patients can find you real quick, Dr. Talebian?
CCRM New York. Also, feel free, anyone, to email me. It's my first initial last name at ccrmivf.com. So, and just want to say I'm really, really grateful that I have Dr. Sabo, Dr. Goldstein, sort of in my back pocket to help with patients, because as Dana can tell you in her journey, definitely it's a team effort here, and we're all working together with the patient included in that. So I feel very grateful that I have such great practitioners also, all with the same goal in mind.
And trust us, we all get very excited when we hear good news from any of them. We're so excited. Dr. Sabo, where can they find you?
My clinic's called Lily, Lily plus Horn, Lily and Horn. And my email is mary@lilyandhorn, lilyandhorn.com. And I too am honored to share patients with these amazing doctors and help people like Dana along their journey. And, the collaboration I think is key. If you can if you can assemble a care team for your journey, it can make a huge difference. Even people who go through terrible, terrible journeys and experience really traumatic things, come out the other side loving, living life, with the right support. So, please encourage your doctors to communicate with other providers and create a team for yourself.
Awesome. Thank you so much. Dana, thank you for coming in today too.
Of course.
All
Thank
right.
you.
Well, everyone have a fabulous weekend, and Passover and Easter or whatever you
Yeah.
celebrate. And hopefully spring is around the corner in New York, or some sunshine at least. But thank you all for joining us. We really appreciate